Welcome to our discussion on post-pericardiotomy syndrome, often abbreviated as PPS. This is a complex condition that can arise after heart surgery or other procedures involving the pericardium, the sac surrounding the heart. Join us as we explore its causes, symptoms, and management. The exact cause of PPS isn't fully understood, but it's generally believed to be an autoimmune or inflammatory response triggered by injury to the pericardium during surgery or other invasive procedures. Procedures like cardiac surgery, including valve replacements, coronary artery bypass grafting, and even ablation procedures, can disrupt the pericardium. Trauma to the chest, infections, or even certain medications can also sometimes lead to PPS. Essentially, the body's immune system mistakenly identifies the damaged pericardium as a foreign invader, leading to inflammation and the cascade of events that characterize PPS. Now, let's delve into the pathophysiology. Following the initial trigger, the immune system releases inflammatory mediators such as cytokines and antibodies. These substances cause inflammation of the pericardium, known as pericarditis, and the pleura, resulting in pleuritis. This inflammation leads to the accumulation of fluid in the pericardial space, causing a pericardial effusion. In some cases, this fluid buildup can compress the heart, leading to cardiac tamponade, a life-threatening condition. The inflammatory process can also affect other areas of the body, contributing to the systemic symptoms associated with PPS. Epidemiologically, PPS occurs in a significant percentage of patients undergoing cardiac surgery. Estimates vary, but it's believed that between 10% and 40% of individuals who have heart surgery may develop PPS. It's more common in children after cardiac surgery than adults, and it can occur weeks, months, or even years after the initial procedure. Certain patient populations, such as those with pre-existing autoimmune conditions or those undergoing complex cardiac procedures, might be at a higher risk. The signs and symptoms of PPS can vary in severity and presentation. Chest pain is a hallmark symptom, often described as sharp, stabbing, and worsened by breathing or lying down. Other common symptoms include fever, fatigue, shortness of breath, and a general feeling of malaise. Patients may also experience a pericardial friction rub, a scratching sound heard through a stethoscope, indicative of inflammation of the pericardium. Additionally, symptoms of pleuritis, such as pain with breathing, might be present. In severe cases, signs of cardiac tamponade, like lightheadedness, rapid heart rate, and swelling in the legs, may occur, requiring immediate medical attention. Diagnosing PPS involves a combination of clinical evaluation and diagnostic testing. A thorough medical history and physical examination are crucial. An electrocardiogram, or ECG, may show characteristic changes associated with pericarditis. Chest X-rays can help identify pleural effusions or an enlarged cardiac silhouette, suggesting a pericardial effusion. Echocardiography is often used to visualize the pericardium and assess for the presence and size of pericardial effusions. Blood tests, including inflammatory markers like C-reactive protein CRP and erythrocyte sedimentation rate ESR, can help confirm the presence of inflammation. Ruling out other potential causes of chest pain and inflammation, such as infection or other autoimmune conditions, is also an important part of the diagnostic process. While there aren't distinct types of PPS in the same way we classify other diseases, PPS can manifest with varying degrees of severity. It can range from mild, self-limiting cases to severe, life-threatening complications like cardiac tamponade. Furthermore, the timing of onset can also vary, with some patients experiencing symptoms shortly after surgery while others develop PPS months or even years later. This variability in presentation contributes to the complexity of managing this condition. Treatment for PPS aims to reduce inflammation and alleviate symptoms. Nonsteroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen, are often the first-line treatment for mild to moderate cases. Colchicine, an anti-inflammatory medication, is also frequently used, often in combination with NSAIDs. In more severe cases, corticosteroids, such as prednisone, may be necessary to control the inflammation. For patients with cardiac tamponade, pericardiocentesis, a procedure to drain the fluid from around the heart, is required. In rare cases, surgical removal of the pericardium, known as a pericardiectomy, may be considered if other treatments fail or if the condition becomes recurrent. Unfortunately, there's no definitive way to completely prevent PPS. However, certain strategies can help reduce the risk. Minimally invasive surgical techniques may be used to minimize trauma to the pericardium. Early recognition and treatment of pericarditis after surgery can also help prevent the progression to PPS. Some studies have explored the use of prophylactic medications, such as colchicine, after cardiac surgery to reduce the incidence of PPS, but this is not yet a standard practice and requires further research. The prognosis for PPS is generally good with appropriate treatment. Most patients respond well to medication and experience resolution of their symptoms. However, some individuals may experience recurrent episodes of PPS, requiring long-term management. Cardiac tamponade, if it occurs, can be life-threatening, but prompt diagnosis and treatment can lead to a full recovery. Recent research has focused on identifying biomarkers that can predict the development of PPS and developing more targeted therapies to reduce inflammation and prevent recurrence. Scientists are also exploring the role of genetics and individual immune responses in the pathogenesis of PPS, which could lead to personalized treatment strategies in the future.